of chapters that we will be testing on, and who knows when in the coming weeks. But this is a important chapter into what we do as respiratory therapists. Is providing medicated aerosols. So we'll talk about a lot of different types of aerosols that we could provide medication through. This is not the same aerosol as a large volume nebulizer that we use bland aerosol therapy for. This is the actual placement of medications. We will talk about anything and everything there is to know about respiratory medication devices without really getting into the pharmacology, the drug names and things like that. I think on, what's today? Today, I think next week, I think I have maybe just one or two drug names that you absolutely have to know for those particular devices, but I don't recall any drug names per se that we will be discussing here. And trying to do it for a reason. Next semester, you guys actually have a pharmacology class with me when, you're going to hate me for all those drug names and the crazy spellings and pronunciations. That's for next semester. That's not just yet. But this will be a help when we get to those drugs, because at least you'll be familiar with the devices. And that's what part of this chapter is, all the different devices that inhaled medications can come through. So, aerosol, just like we talked about bland aerosols are a suspension of solid or liquid particles in a gas. We can visually see it. We can see the aerosol that's being created. Even if it does contain a medication, we can see it. There are different types, fundamentally different types of aerosol generating devices. Atomizers, which something I remember my grandmother having that had kind of perfume inside of them and would spray. That's an old technology. Thank goodness we don't have atomizers that we have to use anymore, but I actually have one. It's in my office. I kind of have a little museum section of my office of old respiratory stuff from way back when. Nebulizers that can be powered either pneumatically or electronically. And then inhalers, which is a very broad, very generic category that we'll spend most of our time discussing all the different types of inhalers. And you may think, I know what an inhaler is. I have one, or I've seen someone take one. Well, what you've seen or what you've taken is perhaps one type of inhaler. But you're going to be sadly mistaken at the end of the day how many different types of inhalers there are out there. All right, so for aerosol drug therapy, the aim of aerosol drug therapy is to provide a therapeutic dose of a specific medication or drug to a desired site of action. Now, depending what our target is, we could be targeting the nose, the throat, large airways, small airways, or alveoli, depending what we're trying to, where we're trying to deliver that medication to. And we'll talk about some of those different locations here in just a bit. But by giving a medication through an aerosol, it's not having to go through the entire body like other forms of medication delivery would entail. For example, a lot of these medications, they probably can put them and make them in a pill or in a liquid that we could ingest. But guess what? That medication is going to have to go through several systems to ever reach our bloodstream, then to pass through several organ systems before it ever reaches our lung. Meanwhile, the drug is being broken down. Perhaps side effects that could occur with these dosages of medications could happen, as opposed to putting the drug in an aerosol, whereas again, if our target is the lung, they're inhaling that directly to the target location, and it's not having to go through the entire body system. So it definitely, I'm not saying there's no side effects with any of these medications, but it lessens the potential for side effects if we instead gave that drug orally through a pill or a liquid form. So if we were to get the same therapeutic effect, we would have to give much more of that medication if we put it in a pill or a tablet before that dose would ever be able to again, reach the lung and give the target outcome or the desired effect that we're looking for. All right, the next couple slides, some definitions, and I tried to put the term I'm trying to get you to grasp in bold here, so bear with me as we go through it. So aerosol output, the mass of fluid or drug produced by an aerosol generator. That could be your nebulizer, that could be your inhaler. For actuation, I simply mean the puff of the inhaler, okay, fancy way of saying the puff, right? Or activation of the inhaler, or over a period of time. For example, a nebulizer, a medication that's given via nebulizer, the patient's continuously inhaling this medication. They're not just taking one inhalation of this nebulizer and then that's the dose, that's it. As opposed to an inhaler, where the medication may come out in just one puff. That's how the patient's going to receive that medication. Just one puff or two puffs or however many actuations or puffs they're required to take of that medication. So the term emitted dose, that describes the mass of the drug leaving the device, nebulizer, inhaler, the emitted dose. So if I had a nebulizer up here in front of the room right now and I'm running it and it's blowing its smoke, we're looking at its emitted dose, that's coming out of there. If I had an inhaler and I depressed it and sprayed one puff into the air, you just saw its emitted dose, all right? So that's what's leaving the nebulizer, that's what's leaving the inhaler. Now, only a portion of that emitted dose will be inhaled. We call that the inhaled dose. So even though you think, well, I put that nebulizer in my mouth and I inhaled what was coming out of it, I don't get everything? No, you don't. Or the inhaler, you depressed that inhaler, it came out, you inhaled it in, oh, I didn't get everything? No, you didn't. Now, we'll talk about techniques to try to maximize what the patient receives, of course. But just understand me, not everything that's coming out of that device, that aerosol generator, will the patient be able to inhale in. And even if they do inhale it in, is all of that going to reach the target location? Is all of that going to reach the lung? No, only a portion of the inhaled dose actually reaches the lung. We call that the respirable dose. Beyond that, we can have some particles that are in that aerosolized dose that never even deposits in the lung, and the patient turns around and exhales it with their next breath. And so just understand, not everything coming out of that nebulizer, not everything coming out of that inhaler is going to get deposited in the lung. And I know many times we just assume, oh, it's there, they inhaled it in, and all of that got in. Not necessarily true. All right, so 3 key mechanisms here for aerosol deposition. Inertial impaction, gravimetric sedimentation, and Brownian diffusion. And I'll talk about all 3. The first one, inertial impaction. This deals with aerosols that collide and that are in motion, depositing on a surface. This really focuses on the larger particles in an aerosol. And by definition, what I'm going to call larger particles are something over 5 microns in size. This funny looking little U with an M, microns. So these deal with larger particles. And what inertial impaction means is these larger particles have greater inertia. These larger particles will move in a straight line down into the airway, and again, these larger particles will then impact the airway surface. These larger particles, again, have greater inertia, greater forward momentum, and they will impact. As opposed to things under 5 microns, so these smaller particles, guess what they can do? They can make the twists and turns in the airway because of their particle size. Larger particles impact sooner. And if, again, you're expecting this medication the patient's inhaling to get down to the alveoli or get down to the lower airways, well, if the particle size is too big, guess what it's going to do? It's never going to get that far down. It's going to impact the surface much sooner, the airway surface much sooner, because it can't make the twists and turns through the lungs.
So the particle, like when it hits the first wall, does it stay there, or does it like kind of like bounce
No,
off?
it will stay there.
Okay.
That's where it will impact. But if you think about it, depending on what our target location is for this inhaler, this nebulizer, maybe it's the asthmatic patient, we're trying to get to the small distal airways that are constricted, right? Well, if everything's depositing in the larger airway, that aerosolized medication is never going to get to where we're trying to bronchodilate or open up the airway. Sedimentation. This deals with particles settling out due to gravity. Again, the larger the particle, the sooner it will settle. This represents, and the reason for deposition for particles between 1 and 5 microns in size. And this is why we typically encourage breath holding with some of our aerosolized devices to try to maximize aerosol deposition. And so if we can have the patient inhale the medication and do what? Hold their breath, that will maximize deposition and cause the particles to settle into those areas that we want it to settle in. As opposed to just inhaling it and exhaling it, again, you're not going to receive as much medication as if the patient can do a breath hold. And we'll talk about that with the different devices as we go through. The last one, Brownian diffusion, or just simply diffusion, this deals with the very, very small particles, generally under 3 microns in size. These are the particles that could potentially reach the alveoli. Again, really reach the end point of the lung passageway. Particles that are exceptionally small, anywhere from 0.1 to 0.5 microns in size, may be so stable that they never even deposit and are exhaled with the patient's next breath. And we'll talk about particle sizes and we can see, again, depending what our target location is in the airway. All right, so particle size, again, can vary depending on the type of aerosol generator. Can also vary depending on environmental conditions. And we'll go over that when we talk about each one of these different devices in just a minute. Aerosols are three-dimensional. Okay, three-dimensional. So when we talk about their particle sizes, we relate them to this MMAD, mass median aerodynamic diameter. Again, because aerosolized particles are three-dimensional in size. Speaking of sizes, particle sizes. Well, what's our target location that we're trying to get this aerosol to? Are we trying to target upper airway, nose, larynx? Well, then particle sizes for that location have to be somewhere between 5 and 50 microns in size. If no, I don't want to target that location, I want to get much further into the lung, obviously there's a particle size for that location. And so if I tell you, well, this aerosol generating device can provide 50 micron sized particles, and you're expecting it to reach the lower airways, that particle will never, it's too big. It's going to deposit much higher. When you think about someone that takes a nasal spray, let's say an Afrin, over-the-counter nasal spray, nasal decongestant spray. If you just squeeze that, you can see that aerosol spray into the air, correct? If I get your albuterol inhaler and squeeze it, that's going to still create a mist, it's going to create an aerosol, it's going to spray in the air, but what's the difference between the two? That Afrin nasal spray, the particles are much larger than, say, your albuterol inhaler. Because, again, we know where we want that albuterol to target, that lower airway, versus the nasal spray, we want it just to stay up here. And so the particle size is smaller. So don't think that when someone uses an Afrin nasal spray and they inhale this aerosolized mist, that, oh, that's getting way down deep in the lungs. No. Because the particle size is only staying there in the sinuses, only there in the nasal cavity for its intended purpose. Aging. Aerosol particles will age. So the longer they're in aerosol, the more that time will affect them. More they will age. So how it ages depends on what is the aerosol composed of, its initial particle size, and Do you think, again, if we're talking about aerosols, that moisture in the air, humidity in the air could potentially impact the particles? Absolutely, absolutely. Aerosolized particles are hygroscopic, meaning they'll retain moisture. So in high humidity environments, sure, they're going to start to retain some moisture, which means their particle size is going to get bigger. How long they're in the suspension, and then other ambient conditions. And we'll talk about some of these things as we go through. Particle size isn't the only determinant for deposition. Okay, there's some things that, depending on the device we're using, some of those things are out of our control. I can't physically change the particle size coming out of this nebulizer versus this other nebulizer. That's predetermined based on the device, or this inhaler and this type of inhaler. That I can't change. But I can potentially coach the patient to be able to receive more of that medication. For example, their inspiratory flow for some of these devices. And I'll make a point as we go through some of these devices, when we tell the patient, coach the patient to take this medication, some of these devices we will have to tell the patient to take in a nice slow breath. Versus others, we're going to have to tell them to take a big, fast, quick breath, strong breath. Again, depending on the device. Flow pattern, respiratory rate. Again, am I going to receive as much medication if I'm breathing rapidly with that medication, or do you think probably a slower respiratory rate would maximize aerosol deposition? And you're true. A slower respiratory rate would. Inhaled volume. Do you think it matters whether I take a shallow breath or a deep breath as far as how medication is going to be deposited? Of course. And it can vary depending on what sort of device we're talking about. If we talk about our inhaler, do you think it would be best for the patient to take a nice big deep breath, or should they just take a regular shallow normal breath? Well, again, if our purpose is to get that medication down to the lungs, yeah, I want to tell them to take a big deep breath. IE ratio. Again, in that case, I don't necessarily want a normal IE ratio that you and I are doing right now. If my focus is on, well, when is that medication going to be received? During inspiration. Well, I hope they spend much more time in inspiration to pull that breath in. Breath holding, of course, we just mentioned that. And not every one of these aerosol generating devices will I have to encourage breath holding with. But there's some absolutely you have to make sure they do a breath hold. If they can't, and of course some patients can't do a breath hold, say, as long as you or I, maybe we have to modify that therapy. Again, it just depends on what the patient is like. All right, hazards. Now, we can spend all day talking about hazards of aerosol therapy, but let me first say, for any aerosol therapy, when we're talking about hazards, most likely the complication is from what's in the aerosol, the medication itself. Has nothing to do that we chose a nebulizer versus an inhaler. It's what the medication was, and that's the reaction the patient may have. So, number one, when we talk about hazards of aerosol therapy, it's more than likely due to the drug, not the device itself. But other things related to the device, infection. You know, if we have an inhaler, now this is going to be a crazy analogy, but if we had an inhaler, and it contains the medication that the next 6 patients have to receive, do I use the same inhaler on all 6 patients? Of course not. Again, you wouldn't want to have an inhaler put in your mouth that was in the patient next door, right? I know, crazy analogy, and we would never do that. But infection is a possibility. Do you think when somebody takes their nebulizer, and we set up the nebulizer and we let the patient kind of run with it, when it's all said and done, do you think we or the patient could potentially contaminate that nebulizer? Because those nebulizers are not a one-time, one-and-done deal. It's, we're going, okay, we'll see you in 4 hours, we'll see you in 6 hours, and we'll do this again, and I got to put that nebulizer on. So again, there's potential for contamination there. If I'm not being careful what I'm doing, or the patient's not being careful what he or she is doing. Airway reactivity. There's some patients whose airways are going to be a little more sensitive than others. I like to use the term twitchy. Their airways are very sensitive, so you give them some aerosol that could put them and set them off, maybe in bronchospasm, which for many of these things, we may be giving medication to reverse bronchospasm, and because we're given an aerosol, that's one of the potential side effects is bronchospasm. Systemic effects. So systemic effects means things that could affect the whole body from aerosols. So those are things, I think we mentioned, just touched on it last week. With bland aerosol therapy, it can cause overhydration of the patient. You're giving them all this extra moisture, so it can potentially overhydrate a patient. Even eye irritation. Again, depending on the device, the aerosol generating device we choose, we need to be careful. Again, if we're creating an aerosol for them to inhale, I'm not creating an aerosol so it can go into their eyes. And there is very specific medications, we'll talk about those meds next semester, but there's very specific medications that can cause problems with the patient's eyes. Especially if the patient has glaucoma, we can make things worse by giving them an aerosol and allowing the aerosol to get to their eyes. Cleaning, yeah, we'll talk about cleaning some of these things, but obviously, I don't want to store these things in a dirty location. If it's something like a nebulizer that's going to be reused, we do have to kind of clean it before we can use it again. Or if it's a home care patient, make sure the patient understands how to clean it before they use it a second time, even though they're the only ones using it. All right, so for effective aerosol therapy, it does require a device that quickly delivers sufficient drugs to the desired site of action with minimal waste at a low cost. And I almost want to choke when I say the word low cost, because some of these things are very expensive. Not getting into dollars and cents here today, we'll probably talk a little bit about the cost of the medications next semester, but again, some of these things are ridiculously expensive. I don't know why they like to use the term low cost, but I guess when it's all said and done, preferable if something is not overly expensive. But what's on the screen now is all different types of aerosol generating devices. Many times, and again, not saying it's any one of us in here, but many times people think, oh, you have to take a breathing medication? Oh, that means it's only one of two things, a nebulizer or a metered dose inhaler. It's not true. Look what's on the screen. There are nebulizers, there are metered dose inhalers, and there's a lot of other stuff that's on the screen. I feel, I can say I feel for you guys because you have to learn all this stuff, and you guys will learn it in time. You have no choice. But I feel for our poor patients who have multiple different types of aerosol generating devices. That's how they receive their lung medication, their breathing medication, with so many different types of devices. And do you think our patients get confused? Absolutely. Absolutely they get confused. And they're going to turn to us to help them understand how their devices work. And this is just a smattering. This is not the entire list of things that they could potentially have. This is just a smattering. This is actually what we have in our lab. So I took a picture of these things all set up in the lab one day. But there's even more than this.
Isn't that purple circular one like for COPD?
I would say, and I'm just rolling it out here, that probably a good 80 to 85% of what's on the screen is for COPD. But you're right, yep, that purple one can be used for COPD. Any excuse I can use to use the acronym COPD, I'm going to do it. All right, so yeah, mic drop. So we'll talk about pressurized metered dose inhalers. Pressurized metered dose inhalers. Now, what's on the screen right now is not a pressurized metered dose inhaler. This is a 1930s era nebulizer. 1930s era nebulizer. So patients who had asthma, this is how they would receive their aerosolized medication. In this glass device with a bulb on the end that they would squeeze the bulb to generate an aerosol. It would come with a glass bottle with a glass dropper that they would have to pull up a certain number of drops of liquid medication and place it inside the device. Now, what's the problem with this? It's made of, again, glass. Do you think they would break?
Yeah.
All the time. All the time. And so that would be a frustration. Another thing, the medication itself would have to be refrigerated. We think about today, someone who needs an inhaler, couldn't they put it in their own pocket or their purse and go wherever and use it if they needed to? But in a situation like this, sure, I guess I can carry that in my pocket and hope I don't sit down too hard and smash it, or ladies in your purse, that it gets smashed because, again, made out of glass. But this does me a lot of good if I can't access the medication that needs to be kept refrigerated. So this picture is a 1930s era product. 1950s, they were still using the same thing. 1954, 55, a 13-year-old girl who was tired of breaking her glass nebulizer, glass aerosol producing device, went to her father and I should say this, her father was the president of a pharmaceutical company, and said, Dad, how come you guys can't create a aerosol generating device just like the hairspray that I'm using on my hair? And so he thought about it and said, that's a great idea. That's a great idea. And so he put his people on it, his scientists, to come up and figure a way to create this medication in some sort of aerosol form like hairspray. And this is what they came up with. 1956, the first metered dose inhaler. Now, we'll be, that looks like it still does today. A little different, but essentially it's the same format that it's in today as it was in 1956. What's that?
Did he cut her a royalty?
I hope so. I hope so. I
I'm
hope
sure she
so.
inherited it.
Where this would not have to be kept refrigerated, wasn't made out of glass. The liquid medication's inside with a propellant that helps to create the aerosol, create the mist. So the first meter dose inhaler, the Medihaler, was used. Okay? And it's not really much different today. The pressurized metered dose inhaler. I know you guys can't see these things, they're kind of blurry here, but the Medihaler, even on the first row, I know you guys can't really see that, it says epinephrine. You know what epinephrine's used for? Or what epinephrine is? It's adrenaline. It's going to increase your heart rate, but guess what it also does? It bronchodilates your airways. And so for the asthmatic that airways are collapsed and bronchospasm, it will dilate the airways. And you guys know, what's the side effect? My heart's going to beat out of my chest now. But that was the first. That was the first. The Medihaler. 22.5% more vital capacity right now, again, for your asthmatics. All right, so MDIs, pressurized meter dose inhalers, are the most commonly prescribed method of aerosol drug delivery in the United States currently. It is small, portable, compact, easy to use, and provides multi-dose convenience. There's multiple doses inside those meter dose inhalers. So I can take a puff right now, a few hours, I need another one, I can take another one. A few hours later, I need a couple more, I can still do that, again, following physician's orders, the proper dosing here, but I can still receive that medication with no added additions of medications or needing to store medications, anything like that. It's a pressurized canister containing the prescribed drug in a volatile propellant combined with a surfactant and dispersing agent. Helps to keep the valves in there lubricated, but as long as we use the right technique, and we could use a wrong technique, but as long as we're using the right technique, a uniform dose of medication is delivered every single time. The catch is it only delivers it over what frame of time? One breath. So if they're going to get that medication, you have to make sure they do it right, so they can get that medication in, because if they do it wrong, there's a possibility they're not even receiving any of that medication, or perhaps very little of that medication. All right, so metered dose inhaler, and sitting inside of its actuator. Sometimes people call that a boot that it sits down into. It may look like a boot, kind of a boot-shaped thing. So when the canister is inverted, meaning the nozzle is pointed down and placed into its actuator, a suspension will fill the metering chamber. Metering chamber. When pressed down, that dose that's in that metering chamber will then escape and go out to the mouthpiece, go out to our patient. The high propellant vapor pressure forces the meter dose out through the hole and out through the actuator nozzle. Notice how long it takes to happen. 20 milliseconds. Very, very rapid. Very, very quick. It doesn't take a long time for it to generate an aerosol. It comes out very rapid, very fast. Velocity as that aerosol leaves the device initially is about 15 meters per second, but within 0.1 of a second, it decreases to half of its maximum. Now, I don't care that you know those numbers. I'm not going to ask any questions. Maybe the previous slide, that 20 milliseconds, I could ask that number. These numbers I'm not going to ask. But notice that aerosol, regardless, comes out very, very fast. Doesn't come out slow, it comes out very, very fast. So fast that the patient can't see it, because again, they're inhaling it, so they can't see it. And we don't have a lab this Friday, just to reemphasize, no lab this Friday, but the next Friday when we do have a lab and we'll see all of these, all those things pictured, we'll see all of those things. We'll get the MDI, we'll spray it into the air so you guys can see it, and you can see this. Now, the two things here, HFA, the hydrofluoroalkylane, or CFC, the chlorofluorocarbons, those are the propellants that have been used inside of a meter dose inhaler. The very first meter dose inhaler had that CFC, chlorofluorocarbon, that we found out later was harmful to the ozone layer. Right? Freon, if anybody's familiar, like Freon for your car, your air conditioning thing.
So with the atomic stuff for the inhaler and being used in that single dose, do those spacers change those factors?
Yes, they do. Yes, they do. And we'll get to those spacers in just a second. Absolutely. So the CFC was the original propellant. Okay, this was the original propellant. Now, this goes back into the 80s, late 80s, when we understood or learned about the depletion of the ozone layer by certain products that we were using as a world, as you know, multiple nations. So these CFCs were banned. They weren't banned for meter dose inhalers because we had no other propellant to use. So they kept allowing the CFCs to be in there as the pharmaceutical companies were trying to figure an alternative way to create a propellant, or to find a propellant that would work. It was a little over 10 years ago, 13, 14 years ago, that we saw the last CFC propellant inside of a meter dose inhaler, because at that point they were completely banned. And so HFA was the new propellant. Supposedly causes less damage to the ozone layer, which I just read an article just the other day that is starting to contradict that, so we'll worry about that another time. But HFA is the new propellant. Again, created because it was thought that it doesn't create the same greenhouse gases that can damage the ozone layer like the CFCs. But like I said, this is a new finding, so we'll hold off and worry about that later, but right now the propellant inside our meter dose inhalers are HFA. That's why, and again, I don't want to get too much into the drug names here today, but that's why you may hear a drug name called HFA, such and such HFA, because they're trying to clarify this is the new propellant. This is the new propellant that's in there. But one thing, and I think for us in coaching or teaching a patient how to use an MDI, I think we're past this now. There was a time I was teaching students both of these. If you notice, just based on the picture, the CFC propellant caused the medication to come out there so much faster than it does today. Okay? That's still very fast, don't get me wrong. The HFA is still very fast, but by comparison of the two, it would always come out faster with the CFC propellant. And so it would be something we'd have to coach patients who have used these in the past. Okay, this one's a little bit different. Doesn't really change my technique or how I'm administering it or coaching the patient, but in case the patient was to ask. I think we're past that now. Again, patients that still need their inhaler are probably well used to this one now, this propellant. But like I said, regardless, it still comes out of there very, very quickly, very, very fast. Most pressurized metered-dose inhalers are a press and breathe type device, meaning you press the medication, there's the aerosol for the patient to breathe in. There are some recent developments of some newer style metered-dose inhalers that they're creating. They've had them in the past. They're going through some transition right now, but where you can actually set up this metered-dose inhaler where the medication won't release until the patient inhales it in, where it can be set up to be breath actuated. So we'll kind of hold off on seeing those because as far as I'm aware, there's not necessarily one that's still remaining on the market. But again, with medications, and you guys will get frustrated like I do, medications come on the market and go off the market so rapidly, so fast. I'll say this right now for our pharmacology class next semester. I promise you that there's a fair number of drugs in that book that are already discontinued. And there's probably the same number of drugs that are now new on the market that haven't even made it in the textbooks yet. When it comes to medications, they come and go so fast. And sometimes it's hard to stay current on those. All right, so U.S. Food and Drug Administration requires all metered-dose inhalers to have dose counters on them. So somewhere on that metered-dose inhaler, you should be able to see a dose counter that counts how many doses are left inside of that medication. And everyone can be a little bit different. Some metered-dose inhalers have only 30 puffs in them. Some could have 120 or 200 puffs inside of them. Some may have 60. It just depends on the medication itself and the manufacturer, how many doses they are allowing in there. But even after the dose counter reaches 0, meaning there's no more puffs of medication, a patient or even you could shake that canister and still feel like there's something in there, right? I can feel there's some weight to this canister. And if I spray to the air, yep, there goes a spray. Oh, that was an extra dose. But the dose counter read 0. The reason they are like that, or the reason it will have, not why they're like it, but the reason it happens is what's coming out of there after the dose counter reaches 0, what you're seeing is propellant and not necessarily medication. There's no way to guarantee that that spray still contains medication. What came out may be propellant. And so it's very important to recognize and make sure you're teaching the patient, follow that dose counter. If you know you need this inhaler, and you take it PRN, but you know you're going to need it from time to time, and that dose counter is down to 10 or 20 puffs left, go get it refilled, or go get a new prescription for it if you're out of refills, to keep it fresh. If it counts 0, I don't care how many times, and how many times you could spray it, could be anywhere from 20 to 60, just depending on the device. But there's no guarantee that those 20 to 60 extra puffs contained any medication. All right, so factors that can affect, bless you, metered-dose inhalers' performance. Temperature, environmental temperature where this is being used at. To be honest, this is less of a problem with the HFA inhalers. This is more of a problem with the CFC inhalers, but it still stays in the textbook. So if someone says, I store my metered-dose inhaler in the refrigerator, probably not a good idea. Okay? Should be kept in the glove box of the car when it's 120 degrees outside, but stored at room temperature, that's okay. Nozzle size and cleanliness. Debris can build up on the nozzle actuator while affecting the emitted dose. It's always recommended to make sure the cap stays on when not in use so nothing gets in there. They should never be placed underwater. We used to teach patients that if you wanted to know how much of your medication was left, take your canister and drop it in a glass of water. We used to teach that. And depending how it would float or bob, if it would sink to the bottom, it was full. If it floated on the top, it was empty. If it bobbed and weaved a certain way, that could mean it was either a quarter full or 3/4. I can't remember how we used to teach them. But it would bob or weave. We do not teach that technique anymore. Why don't I teach that? Because it has a damn dose counter. It doesn't have to drop it in water. It tells me the number of doses that are left. And you'll appreciate why we don't teach anybody to drop this in water anymore. What's another type of inhaler we have available to us in our patients? What's known as a dry powder inhaler. What if they drop the dry powder in water? Oh, there goes the powder. So it's the reason we don't teach them anything about dropping these things in water, because we're afraid they're going to make a mistake and get a DPI, dry powder inhaler, and drop it in water thinking they're doing the same thing.
So, I'm just looking at that picture and that metering valve right there, like, it's pretty tall. So, like, if the level of the medication goes down below that, it won't administer any, right?
Correct.
So, like, when you, like, with the dose counter that you're talking about, will it go down to 0 when it reaches the top of that valve, or when it's, like, completely empty?
No, when it reaches its last dose, it's designed to provide. Priming. Make sure you know what the word priming means. And this is our design technology today, what we have. When a meter dose inhaler is brand new, or it's been sitting for a long period of time, the recommendation is that meter dose inhaler must be primed first, which means we're going to waste a dose. We're going to spray that inhaler out to the room somewhere. 1 puff, 2 puffs, 3 puffs, 4 puffs. It depends on the manufacturer. But the number of primed breaths we could do can vary anywhere from 1 to 4, depending on the drug manufacturer and what that particular brand inhaler is. Which means we're doing what to those dosage? Maybe my inhaler only contains 100 puffs. That means if it's brand new or it's been sitting for a while, I'm going to take those 100 puffs that cost me money and say, we'll just waste the first 1, 2, 3, or 4. Again, depending on manufacturer recommendation. Then you can take the inhaler and get the right dose, get the right amount. So, does that sound a little peculiar to you, that we're wasting doses of medication when we are telling patients to prime? Because that dose counter is still going to drop by the number of times we even just sprayed it to the room. Still going to drop by 1 each time we do that. But to be assured of getting the proper dose, priming is necessary. Priming must be done. This liquid medication and propellant and surfactant and other dispersing agents that are floating in here are a suspension. They will settle out and separate. So if they settle out and separate, I'm going to have to clear that from the metering valve first to make sure what's now going down into that metering valve is a sufficient, well-mixed dose of medication. We'll go over the technique in just a second, but part of mixing is you do have to shake and mix up the MDI before you can administer it, before you can even prime it, to make sure everything gets mixed up very, very well. Now, timing of the actuations. Again, actuation, fancy word of saying puffs. So timing of the actuations. So if a patient's taking multiple puffs of their inhaler. And so, let's say this patient's prescription says to take 2 puffs of this inhaler PRN, as needed. That doesn't mean they're going to go, okay, there was 2 puffs, right? No, they're going to take 1 puff, inhale that in. They're going to wait 30 to 60 seconds before they take puff number 2. Okay, so I just want to be clear. We're not telling patients, yeah, spray it all right there at once and take it all in one big breath. No. 1 breath at a time. And if you have to take more than 1, 2, 3, 4, 6, whatever the case may be, wait at least, minimum, 30 to 60 seconds between those actuations. Because what's the patient going to have to do when they initially take that breath in? What are they going to do? They're going to hold it. They're going to do a breath hold before they exhale. And so that's going to obviously take time too. And so you think, oh my God, we're going to wait 30 seconds between puffs? Yeah, at minimum, to ensure a good adequate dose. Now they don't have to prime between. The priming's already been done. Again, if the inhaler's been sitting for an extended period of time, and if you want to know, well, what defines extended period of time, I would say you have to read the manufacturer's package insert of that meter dose inhaler. And if anybody's ever gotten medication where there's a package insert, has anybody ever tried that? You open that thing up, it's like this, and the font is like 2. I need my reading glasses and a magnifying glass, and I still can barely read it.
Literally amazed how they fit that also in the little old box.
Oh yeah, because you open one of those things up, it's like this, it's like a poster size. But it's all folded up really nice and neat and convenient, and it's inside the box where the meter dose inhaler is. Alright, so let's talk about technique. Technique for a meter dose inhaler. Extremely technique dependent. Again, ask yourself this question. When do they get the medication? Over multiple breaths or over potentially one breath? That one breath. And so if they don't do it correctly, guess what? They're either not getting their medication or they're not getting an adequate dose of their medication. So it's extremely important that the patient is taught the correct way. How about line 2? 2/3 of patients and healthcare providers don't perform it correctly. Who teaches patients how to do a meter dose inhaler? Respiratory, nurse, doctor, who else? Pharmacy, the pharmacist, pharmacy tech. YouTube, there you go. I don't need any help anymore, just go to YouTube, it's all there. Who knows if it's right or not, but it's there. Somebody says it's right. I guess that makes it true. So yes, there's a lot of folks, including healthcare practitioners, who do not know how to perform an MDI properly. Or, if it wasn't taught by a healthcare professional or YouTube, the person pulls out the package insert and goes, I think you do it like this. Okay, that's how we'll do it from here on out. Thorough education of a patient can take, again, this is not a rush job, anywhere from 10 to 30 minutes, depending on the patient and their comprehension level. It would be great if they can demonstrate in front of us. Because, just like you guys, I can say it, but when we go to the lab and you perform it like, that's not what I said, you've missed like 6 steps. Okay, let's practice it again until, okay, you can demonstrate in front of me or Desmond that you know what you're doing, that you know how to operate that device or to do that inhaler. So patient education is of greatest importance. We cannot just assume because a patient's taken an MDI for umpteen years that they've been doing it correctly. You'd be shocked and surprised how many times I've taught a patient how to do it and they go, nobody's ever been that thorough with me before, nobody's ever taught me that way before. And I'll tell you why it needs to be done this way and not the way they were doing it, and what the mistake was and what they were doing wrong. So don't assume anybody knows exactly what they're doing with their meter dose inhaler.
Well, sometimes doctors make mistakes, and I try twice as hard to fix them. Using your inhaler,
All the time, go through one a week.
you sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Oh my God.
I would love to have known what he would have said to her.
I
after
love that show.
If you ever watch House, he's arrogant, he's cocky, but funny as heck. Yeah. No, I'm supposed to inhale it in.
Was
right?
not expecting that.
All right, so as far as steps go, and I think that I'm kind of starting the steps. Yeah, I'm kind of starting the steps right now. Again, I wish I could fit it all on one slide, but it's not that simple or not that easy. But all right, so number one, remove the cap. There's a cap going to be covering over the end of it. Can't do a whole lot if the cap's left on. So remove the cap. Warm the canister. Don't put it in the microwave. Don't heat it up on the stove. Just in your hand, just for a few seconds. Because what are you going to be doing anyways? You're going to be mixing it. You're going to be shaking it up real good anyways. So if you've warmed it some in your hand, you can sit there and shake it vigorously. 10, 15 seconds, 30 seconds, whatever the case may be, but vigorous mixing of that meter dose inhaler. What we're doing, if we don't mix it, there's not a good mix. You can notice kind of the shading here of the colors. There's not a good mix, and that's what's going to come out. If I shake it up and mix it up well, after I've sprayed it, waiting for the next spray, the next inhalation, I've mixed the suspension or the solution much more effectively. Again, not only is medication inside that, but also the propellant. Okay, so we need to make sure there's a good mix. So remove cap, warm canister, shake vigorously, prime per manufacturer guidelines, manufacturer directions. Again, if it's been sitting for a while, this is something they use fairly often, then priming you don't have to worry about. But if it's been sitting for, let's say, a week or two, yeah, you probably want to prime it again before you use it. All right, two types of acceptable techniques. Now, one definitely is more popular than the other, but I want you to see there are two acceptable techniques: an open mouth technique or a closed mouth technique. Now, the open mouth technique was probably more important when we had the CFC inhalers, because they were coming out of there even faster than the HFA. And so the school of thought with the open mouth technique, again, holding the inhaler away from the open mouth, they say about 4 centimeters, which is about 2 finger widths away, with an open mouth. So when you would spray it, the school of thought is, okay, that initial spray is going very, very fast, but it will begin to decelerate by the time it gets to the back of the oral pharynx for the patient to inhale. Okay, that's still currently an acceptable method. But with this does carry me some concern for my patient. Where is the inhaler in relationship to the patient's eyes when they hit that spray? Okay, so that would be an issue, right? The closed mouth technique simply means the inhaler mouthpiece is inside the patient's mouth, making sure the tongue stays out of the way, that the tongue's not blocking the opening there. Okay, so keeping it there between the lips, teeth, tongue, everything out of the way. Now here's the hardest part of the technique, and this is what people do wrong. For both techniques, patient breathes out normally first, and then a slow inhalation. Begin a slow inhalation, then activate the inhaler. Okay, one more time. Have the patient exhale normally, inhaler in the mouth, begin inhalation, then press the inhaler and continue inhaling. As opposed to the wrong technique, and here you go, here's the wrong technique, you spray it, then inhale. Because guess what happens to the medication when you depress it? It blasts back there, hits the back of the oral pharynx. And then you inhale, well, most of it just impacted the oral pharynx, not getting to the lungs. That's why you got to start breathing in first. Now, I'm not saying take a breath in and then hit the inhaler. No. You're just beginning to start inspiration as I begin to press that inhaler. So start breathing in first. A millisecond later, go ahead and then depress the inhaler. That way you're already inhaling. That medication will then be able to reach the lung. Continue inspiration to total lung capacity. So yes, I'm breathing in slowly, but I am going to breathe in deeply taking in a nice, big, deepest breath in possible, and then the breath hold. And I say this, ideally for 10 seconds. And I know there's going to be some patients out there that can't hold their breath for 10 seconds. And I'll concede, okay, can you do it for 5 seconds? Oh, I can try. Okay, well, I say 5 seconds is better than no seconds. So even if they can give me half of that 10, if they give me 3 seconds, if they give me something, that's still going to help with aerosol deposition. They can give me that breath hold. But ideally, 10 seconds, if at all possible. Then have them relax and breathe normally. Okay, they've taken their first puff of their mini-dose inhaler. If we have to go through the process again because they're supposed to take 2, then how much time do I allow to elapse? 30 to 60 seconds, and then we can go through the process again. I would say, I don't have to prime between those puffs. I would say, as I'm doing a breath hold, I'm probably still, if I'm the patient, I'm probably still just making sure things stay mixed up very well, waiting for my next, 30 seconds, let me do it again. And so as far as shaking, priming doesn't have to happen again. The cap's already off. I don't have to warm it. I've already warmed it. But as I'm doing that breath hold, waiting for the next 30 to 60 seconds elapse, I'm probably still just going to shake that inhaler just to make sure it stays mixed up well.
Breathe into the nose.
Well, if you want to get medication, you need to breathe through the mouth. Because that's
No,
where the
like,
medication is.
just like when you spray and it just goes.
Well, again, regardless, open mouth, closed mouth technique, you're breathing through the mouth. All right, caution not to spray it into the eyes. Again, not getting into drug names or anything like that today, but if your MDI contains a steroid, when the patient's finished with that medication, they must rinse and spit out that water that they're rinsing their mouth out with. It's so their body doesn't absorb the steroid. So that's not necessarily true for every inhaler, but if the inhaler contains a steroid, they do have to make sure they rinse and spit after they've taken their accepted number of puffs or inhalations.
They wouldn't absorb the steroid anyway when it travels down?
Yes, they could. And I don't want them to absorb it any other way but inhaled.
Okay.
Okay? So they can't absorb it into their body, into their system, which then leads to potential side effects of having steroid. If they allow that to stay in their mouth and they don't rinse or spit after, they can develop a fungal infection,
Okay.
a thrush infection in the mouth, which is not comfortable for a patient to have that. So it's why we tell them to rinse and spit. Now let's talk about some accessory devices. You can accessorize your meter dose inhaler. You can bling it up if you want. I'm kidding. But there are accessory devices that can go with it. These are designed to reduce oropharyngeal deposition. Again, making sure the medication doesn't stay deposited on the back of the throat. And the hand-breath coordination. Now, I could teach you guys to do meter dose inhaler and you would do it fine. But there's some of our older patients that may just have trouble getting the timing down of inhaling and then depressing the canister while continuing to inhale. Some of our older patients may have Parkinson's, so it's hard for them to navigate this. And so the biggest issue with meter dose inhaler is the hand-breath coordination. And so by using some of these accessory devices helps to eliminate that problem. So there's devices, Faith was just asking, called spacers. There's another very similar device known as a holding chamber. They both do the same thing. They create a distance or a space between that aerosol plume that's being created and the patient to inspire it in. Okay, so spacers are valveless chambers. If I empty my water bottle here and I cut a small hole into this end and stick an MDI in it, I've just created a spacer. I created a distance for that medication. I've seen people have toilet paper rolls. That technically can be a spacer. Again, one end to the mouth, one end for your inhaler to spray, again, to just try to hold and capture that medication for the patient to inspire in. What you will see is a spacer / holding chamber today that is a device that has valves, one-way valves to make sure the medication can't go back out, can't leak back out like it could with a technical just a spacer, but with a one-way valve holding chamber to allow that medication to be more easily deposited into the lung. Did I see a hand going up with a question?
No.
No, I'm sorry.
Also you said some can have both the spacer and holding chambers?
We will use the word synonymously many times in practice. It's a holding chamber, but we call it a spacer, or it's a spacer and I call it a holding chamber. Again, these things are almost used synonymously. But to make sure we're correct on the test, a spacer doesn't have any valves, but a holding chamber does have one-way valves. Now, a spacer can improve aerosol deposition by 90%. Again, less being deposited in the oropharynx. Spacers can improve aerosol deposition by 90%. Holding chambers can improve aerosol deposition by 99%. So what you're going to see in the hospital when we teach someone to do an MDI, and we have a spacer / holding chamber with us, really it's a holding chamber. Okay? And that's how we're going to coach the patient, what we're going to coach the patient to use. These are just some examples. The two pictured on the left are holding chambers. The one pictured closest to me is simply a spacer. But notice what it does. It creates a distance between where the aerosol plume is coming out and the patient. So if the aerosol, if this has been depressed, there's aerosol in here, now it's ready for the patient to inspire. That timing issue that we said before with an MDI, that was if I'm not using one of these things. If I'm using one of these things, guess what? I don't have to be so particular with my timing. I can depress that meter dose inhaler, the medication's in that spacer or holding chamber, now I can inhale it. Especially if it's a holding chamber, because again, the medication can't go back out the back way, it's a one-way valve. And so as far as trying to get my timing, if I'm using one of these, I don't have to begin breathing in first and then depress the inhaler. The technique we described was if we weren't using one of these. Again, so I'm not using one of these, I have the MDI in my mouth, I need to begin inhalation first, then depress the canister while I'm continuing to inhale. But with this spacer holding chamber, I can depress it, medication is going to stay captured, then I can inhale.
That also would improve, like, not the dose, but how much you're actually receiving or getting in.
That's what I mean by improved aerosol deposition. What's actually getting down to our target locations, absolutely. And notice these things can be mouthpieces, can even be a mask. You know, I know this shows a young child, but what if it's an elderly patient with dementia, they can't figure out the timing part, or maybe even a comatose patient. Now with a comatose patient, again, they won't be taking deep breaths on command, they won't do a breath hold, so there's going to be some limitations there. But now, again, the aerosol plume is right there, waiting for them to inspire it. Questions? Okay, if you kind of notice here, the purple colored area shows without proper technique and not using a spacer or holding chamber, where's most of the aerosol particles going to be stuck or caught? The oropharynx. And some of it reaches, some of the breath will still, or the medication will reach the lung. But with a spacer or holding chamber, less oropharyngeal deposition and more deposition to our target location, the lung. Questions? Meter dose inhalers.
I have a question,
Yeah.
not really about that, but the first inhaler, you said the med inhaler and the epinephrine, is that why it's like not really prescribed that much anymore, the epinephrine inhaler is more over the counter?
That's a loaded question. I'm trying not to get on my soapbox here. Epinephrine is used in resuscitation to get the heart beating again. It's a potent cardiac drug that has bronchodilating qualities, meaning it will cause the airways to dilate. There are newer medications that cause less issues with the heart and actually better bronchodilation. Okay, so again, of course, prescription, has to be ordered by a physician for us. Now, what's over the counter? There is an over-the-counter bronchodilator, classified as a bronchodilator, that contains epinephrine. That drives me crazy that medication is allowed to be taken under no medical observation whatsoever. It is epinephrine. You could read the label on it. It is epinephrine. It is that Medihaler from back in the day that can speed up your heart, but does carry some bronchodilating qualities. Okay? It's over the counter, which means we can go to the store right now and go pull one off the shelf, pay my whatever it costs, 20 bucks, 30 bucks, maybe more. And now I have my pure epinephrine inhaler that has some bronchodilating qualities. But for folks that rely on that to keep their airways open, what stress are they putting on their cardiovascular system? That's my question. And again, United States Food and Drug Administration, why is that allowed to be over the counter when people are using that medication as their primary source of bronchodilation, not being followed by any healthcare provider whatsoever? Again, I'm on my soapbox right now, so I'm going to kind of step off of it for a minute because I have a whole talk about that later. But yes, that is what's over the counter right now. They did ban it for a while, but in the last few years, it's back again. I don't know why. Thank you. I'll preach about it, but again, it's not my decision. All right, let's change gears for a second and talk about the soft mist inhaler. Soft mist inhaler. Now, let me be clear. This soft mist inhaler, which we call the Respimat, is not, I repeat, is not an MDI. It is not an MDI. It uses mechanical energy to create an aerosol, a low velocity aerosol. Whereas the meter dose inhaler created a very fast, high velocity aerosol, this one is a very slow, you may hear the word, I don't know if soft mist. I think slow mist is a better descriptor of it. But notice, that aerosol spray will occur over about a second to a second and a half. Instead of blasting out like the MDI, this comes out a very slow aerosol over a little, God bless you, over a little more than a second's time. Hand-breath coordination is still required, so they still have to press it, but when they press the button, activate the button, that's when the mist comes out, that's when the aerosol comes out. So they still have to time it, they have to be able to time it, but this is going to be much easier to time than, say, a meter dose inhaler. Has no propellant. What did I say about the issue right now that I just read the other day about meter dose inhalers? What I thought was the better propellant that didn't deplete the ozone layer apparently has some sort of environmental concerns, the HFA. So does that mean in the future they're going to look for a different propellant? Maybe so. Or can they transition to a different type of device that doesn't even contain a propellant? This one uses the spring inside of it to generate the aerosol. Doesn't require a spacer, doesn't require a holding chamber, doesn't even have to be shaken. It's actually a solution, not a suspension. So everything in it is well mixed. I don't have to mix it up myself. So I find this would probably be the easier method if we're talking about some sort of inhaler, right? Comparing this to the MDI, right? But only certain medications come in this form. And so that's the limitation right now, is there's only, count them on one hand, how many different medications come in this form. What's that? It's because it's brand new. It's brand new. So of course anything brand new, the price is going to be sky high. Yeah, unfortunately. because it has to be on the market for so many years before it loses its patent, and then somebody else can make the generic equivalent. We'll talk about that more in pharmacology class. Not trying to jump ahead. All right, pretty simple to use. If you can remember the acronym TOP. Turn, open, press. You will turn the device, you will turn the apparatus, that will activate the spring. You will open the mouthpiece, it's a little swinging door here, and then place it in your mouth, press, and then you can breathe in. Now, you don't have to do this every single time, but what's inside the Respimat is a canister that does have to be loaded the very first time. So this will get pushed, you can see it kind of, they're setting it on the table and kind of just smashing it down, locking it into place. And that'll be good for, at least in this example, the 60 breaths that are here. But guess what's another thing, and I didn't put this on the slide, what's another advantage? You don't have to prime it. You're not wasting any of those doses. You are going to receive those 60 doses over the period of time you're using this device. But like they said, this is new. It is a new device. It is a new device. And like I said, also, only a handful of drugs come in this form. That's going to be something, we'll talk about this in due time, that impacts what device we're going to pick is, well, they need this particular medication. What form does this medication come in? Does it come in a Respimat? Does it come in an MDI? Does it come as a nebulizer? Does it come in all? Okay, well, if it comes in all forms, then great. I can pick whatever one I think works best. But what if it only comes as an MDI? Well, then that's the form I'm going to have to be able with.
So the respiratory therapist takes the form?
A physician still will write the order for that, but you know, we can always recommend based on what we have available to us.
And I guess what would work best?
What would be best for them, and again, alternatives, and also perhaps cost for the patient, especially if they're going to be using this when they go home. You know, for example, I could give them a nebulizer in the hospital, but do they have the equipment in the home to use that same nebulizer? No, but we can give them a Respimat or we can give them an MDI to be used in the home. All right, everybody okay so far? But be careful, the Respimat or soft mist inhalers, I know, and I don't like it in the book that they immediately put it right after the MDIs. This is not part of the MDI category. It's part of the inhaler category, but it's not an MDI. This is its own entity. There's the MDI, there's the Respimat, and now there's the DPIs, the dry powder inhalers. Dry powder inhalers have been around for quite a while. Not extremely popular in the beginning. This was an early 1940s era dry powder inhaler. I don't know if you can read the medication on here. You used to be able to see it. Where is it? Oh yeah, it's penicillin. See it there. Part of the word, penicillin. So it was an antibiotic. DPIs do not require hand-breath coordination, don't require a propellant. And as I said, when they were trying to figure out a way to administer some sort of inhaler that didn't contain a propellant, because again, they were banning the CFCs, DPIs begin to take off. In the last 10 to 20 years, DPI usage and the number of DPIs has dramatically increased. The problem with DPIs is every manufacturer that makes their own DPI, it's still a DPI, but how it works is different than the next guys, and the next guys, and the next guys. So when we had MDIs, and an MDI is an MDI, different medications, but an MDI is all fundamentally the same thing. DPI forms, there's so many varieties, and that's the hard part, of how to operate each one of these different variety of dry powder inhalers. So, a dry powder inhaler is a breath-actuated dosing system. When the patient inhales from the device, that's when they're going to get the medication. So they don't have to worry about pressing a button or timing it and having this powder come poofing out or blowing out. No. They activate it. The patient will activate it. We'll go over how to activate these things in just a second. But once the patient's ready, they put their mouth on the mouthpiece and begin to inhale. So that's when they're getting the medication. So it is a breath-actuated dosing system. They do have to, and this is the catch, the patient does have to generate enough force when they inhale to create that powder to be in the proper particle size for them to inhale. So to get that dry powder activated to be an aerosol, the patient does have to generate a certain amount of force, certain amount of pull when they inhale. And so for some of our younger patients or some of our older patients who can't do that, then maybe a dry powder inhaler is not in the cards for them. Already said, don't need propellants, don't require hand-breath coordination, but they do require a high inspiratory flow rate, as opposed to a meter dose inhaler that requires from the patient a low or slow inspiratory flow rate. Dry powder inhalers, they do have to generate a very high inspiratory flow rate. Again, to make sure those particles are in the proper size, that dry powder is in the proper size. All right, the chapter breaks DPIs down into 3 different types. And when we go over the different types, I'll try to mention what type that each one is. They do make unit dose dry powder inhalers that, when activated, will give an individual dose of medication. Some of these dry powder inhalers, we or the patient has to load the dry powder. We or the patient has to actually load it. That's what I mean by unit dose. There's some that contain multiple unit doses, which when you load it, you still have to load it, or the patient has to load it, but there's more than just one dose in there. So they can inhale that, they can wait for how much time before they take the second dose, wait, take another dose, but again, there's not a lot of doses in there, there's only 4 or 8 individual ones, as opposed to the unit dose, it's just one. Probably what would be more convenient for a patient is the multiple dose dry powder inhaler, where there's multiple doses inside of that DPI, waiting to be activated. And we will go over how to activate each one, and then how does the aerosol come out when the patient inhales through the device.
You'll see those in the lab.
Yeah, we will see a good variety of them in the lab. Yes, and you're gonna need to be able to see it in the lab to make it make sense. All right. Now, different factors can affect the DPI's performance. There's some intrinsic resistance factors of the device itself. We really have no control over that. It depends on the design of the dry powder inhaler. Exposure to humidity and moisture. We can have some control over that, or at least we can coach the patient to be cautious and careful. If the environment is humid, it could affect the output of that dry powder inhaler. If the dry powder inhaler is stored in a high humidity environment, like what's that part of our house where we store medications? Oh, that thing called a medicine cabinet that's in what room? The bathroom. Probably the worst place for it to be with the dry powder inhaler, right? We don't want that moisture-rich environment. You got in the shower this morning, everything was all fogged up. Guess what? Your DPI that's sitting in your medicine cabinet, it's getting fogged up too. And what happens, the more moisture that gets in there, what happens to the powder? It begins to clump. And so much for it separating into a very fine aerosol. So, definitely recommended not to store your DPI in a high humid environment like a bathroom.
Could it also not be a good idea to store a MDI in the bathroom too, because of the possible, maybe, I don't know about evaporation, but like,
the moisture is not going to have anything won't affect the MDI, but I think it's just good practice not to store any of our medications in the medicine cabinet. How it got that name decades ago, I have no idea, but I think it's a good school of thought not to store meds inside your medicine cabinet in the bathroom. Patient sensory flow rate, this is probably the 3rd time I mentioned this. They have to be able to generate adequate inspiratory flow. Without it, the DPI is not going to work the way it was intended. And so there's going to be certain patients, you're going to look at that patient and go, yeah, there's no way he or she can do a DPI. Okay, does the med come as an MDI, or does the med come as a NEB or a Respimat? Okay, well, let's try that for this particular patient, because there's no way this particular patient can generate enough flow. So, the technique, speaking of inspiratory flow, the patient must be able to generate at least 40 to 60 liters per minute of flow. When they inspire, they need 40 to 60 liters per minute of flow. Again, with an MPI, how do they do it? Slow. But with a DPI, it has to be, you have to generate lots of inspiratory flow to get that powder into its aerosol form to be inhaled. Because they can't generate adequate inspiratory flows, infants, toddlers, small children, those who can't follow instructions, I'm thinking some of maybe our elderly, dementia patients, slightly confused patients might not be appropriate here. Patients with severe airway obstruction, maybe that's our asthmatic whose airways are really clamped down tight. Maybe they can't generate enough flow because their airways are clamped down. Might not be able to generate adequate flow. And again, when you're looking at flow, well, what is it? 40 to 60. And I will take this a step further. It goes back to grab each one of those package inserts, because each one will say what that magic number is for that particular device. Some will be on the 40 scale, some could be on the 60 scale. So it is important to know, well, what particular DPI am I using and what specific flow for that DPI. But if we're going to just kind of group DPI all together as one, remember the range. That's what I'm going to test you on, is that range, 40 to 60. But there could be a certain brand of DPI that requires 60 and 40 wouldn't be enough. So that depends on looking at that particular manufacturer package insert for that device. Cleaning in accordance with the product label according to manufacturer instructions, but again, makes common sense here. It's dry powder. Don't place it in water. Don't place it in water, please, or else you just completely, wasted all those doses, especially if it was a multi-dose DPI. You just wasted all that powder that was inside the dry powder. All right, so optimal technique. Assemble the apparatus. We'll talk about some of the different types here today. Load the dose, keeping the device upright. Oh, that's another thing I forgot to mention. When you have this device, if you've activated the powder and the device is just waiting for the patient to inhale it. Okay, let's pretend this, my little remote here, that this is the mouthpiece of my dry powder inhaler. If I activate it and I do this, where's the powder going to go? It's going to spill onto the floor. So be careful when we activate these. I mean, it's okay if the mouthpiece stays kind of parallel to the floor for the patient to inhale, but don't have them turn it upside down. I did that one time, learned the hard way with the patient, talked about the device with the patient said, okay, I got it, activated it, was looking at it, and I'm thinking, okay, he's about to inhale it, and he did this, and the powder landed right in his lap. And he looked at me like, what do I do now? I go, we're not going to do that again. Yeah, exactly. Start snorting it. It's white powder. Sorry. So, have the patient exhale slowly to functional residual capacity. Not everything, but just nice passive exhalation. Seal the lips around the mouthpiece, deep inhale and forcibly, again, 40 to 60 liters per minute is what we said. Breath hold should be encouraged, but it's not essential. But it's still, I would encourage it. Repeat the process until the dose is completed. If, for example, we have to take multiple doses. Monitor for adverse reactions and assess beneficial effects. That's a very generic example of how to operate a DPI. But let's talk about the different types. And this is where we get into trouble. This is the moment when you're like, oh my God, I thought it's a DPI. There's different types of DPIs. Okay? And this is just what I'm testing on. This is not every single one that's out there either. The textbook mentions some of these, but doesn't go into very great detail on the device. But like I said, I want us to be comfortable with the devices this semester. So next semester, when we talk about the drugs that come in these devices, it's a little less at that moment for you have to worry about trying to memorize. Because at least the devices you'll have some familiarity with. You can just simply add, okay, that's the drug that comes in that form or this other form. And believe it or not, these are the ones, or of course these are the ones that are approved in the United States. There's probably another 30 or 40 more that could be approved overseas that just haven't reached our market yet. The United States was always the last ones to get that. We let everybody else figure it out or make the mistakes or, oh, that doesn't work. Well, oh, that killed a lot of people. Okay, figure out the errors before we ever accept it into our market. I guess that's a good and bad thing. But there's a lot more out there than just what we will be discussing here, which adds to what? More potential confusion for us and for our patients especially. Because you can have a patient with multiple DPIs and how they operate them, totally different. And they still have their MDI and they still have their nebulizer for some other medications. Again, that picture I showed you, that could be a potential patient out there somewhere that has so many different varieties or types of their inhaled medication. All right, let's talk about the FlexHaler. Now, don't worry about drug names. I'm not going to ask any questions this semester on drug names. So I wanted to give you the device. I just happened to have one that included the drug name. Don't worry about it. I'm not going to ask anything about the drug name yet. That's next semester's talk. But the FlexHaler, it's a multi-dose DPI. There's multiple doses of powder in here. Okay? How we activate it, I think I have another slide here. How we activate it, we take the cap off. To the very bottom, you will rotate. It'll be about a 180-degree turn, and you will hear it click. Okay? You may have to rotate, twist, and twist back, but you will hear a click. The click means the powder itself has been punctured, and it's waiting for the patient to inhale. So you're twisting, you're turning back, you're hearing a click. Means the powder inside of it's been activated. Again, patient exhale normally, passively, place the device in their mouth, inhale deeply. Again, encourage a breath hold, but not absolutely 100% essential, but you still, I would encourage a breath hold. That's the FlexHaler. That's the FlexHaler. The multi-dose DPI. The TwistHaler. Now let me say this, the TwistHaler and FlexHaler, students get those confused all the time. They look similar, but their operation is a little bit different. This also is a multi-dose DPI, so all the powder's already inside of it. How to activate this device, let me step back for a second. The previous one, what did you have to do here to the bottom? Yeah, I don't like to use that word. Turn it back, hear a click. I'll say on this one, the next one, the TwistHaler, simply twisting the cap off activated the device. Simply by taking the cap off, and I'm going to use the word twist for this one. But you can see the confusion, especially that other picture. I took these pictures from the manufacturer's websites, and I guess they don't care. That other company likes to use the word twist for twisting the bottom. This one, simply taking the cap off will activate the device. You don't have to rotate or turn the bottom of this unit. If the patient doesn't believe you, tell them, okay, well, go ahead and inhale this dose. When it's time for the next one, I'm going to come in. Don't open this thing. Let's keep our eye on this dose counter. When you twist or take the cap off, what happens to the dose counter? It will drop by 1. You just loaded it. It's waiting for you to inhale the medication. So once it's been activated, then it's pretty straightforward. Exhale normally, place the device in your mouth, inhale deeply, ideally with a breath hold. But it's trying to figure out how to activate these things and get them ready for the patient to inhale is the hardest part.
Does the powder coat your mouth?
They sometimes, we've gotten better with DPIs. They will add kind of a sucrose type thing, so at least there's some semblance that they feel like they've taken something. When a lot of them first came out, they didn't take it, would not even know or even believe they took it. I remember I was working one day on a floor and got a call from a patient's nurse. Patient had just started the DPI, and the patient's nurse was not familiar with the DPI. It was that purple one, as a matter of fact, that you'd asked before. At the time was new on the market, and the patient said, I've taken this 3 times and I don't think I've gotten any medication. Well, my first clue was when I looked at the mouthpiece, I saw the white dry powder. And I said, well, I believe you've already taken it, and looking at the dose counter, it's already down 3 doses. You took all that this morning? Yes, okay, well, stop. Don't take any more. That was something given twice a day, once in the morning, once at night. Don't take any more. but I'm here all day, and before I leave, at 7 o'clock, I'm gonna come by, I'm gonna watch you take this, and you and I together can make sure you do it correctly. He's like, yeah, I didn't taste anything, and I said, you won't taste anything. They may today have a little bit of a semblance of a sweet taste after inhaling it. But at that time, I came back in right before I left that night and said, okay, take it, I'm gonna watch you. He did it exactly correct. I said, you actually, believe it or not, took that medication. And if you're ever questioning it, look at the dose counter. Did the dose counter, when you activate it, drop by 1? Yes. Okay, well, if you inhaled it in, did your breath hold, then you took that medication. But as far as feeling any different, the patient didn't. All right, so everybody okay? Flexhaler, you're taking off the cap, but you're having to rotate the bottom until you hear a click. The Twisthealer, twist the cap off, you've activated the device. Both are multi-dose DPIs. All right, the Dischaler. This is your multi-unit dose device. It's the only one. Multi-unit dose device. So these things come in a blister pack. Each one of these things represents a different dose of the dry powder. This simply fits into this wheel. When everything is connected back, this gets raised. That actually punctures one of these capsules that's in this foil pack for the patient to inhale. Only one drug comes in this form. It's something you don't see every single day. It's an anti-flu medication. Now, Relenza, I'm not asking you brand names. I'm not asking you what it's given for, so don't worry about that. We'll get to those in due time next semester. But of the list that I'm sharing with you guys today, this is probably the one you'll see the least when you're out there in your travels. All right, the Dischaler. But notice the name, Dischaler, not to be confused with the Discus. Okay? There's that purple device Lindsay was asking about earlier. All right? It has inside of it all the dry powder. So this is a multiple dose DPI. Again, how we activate it will puncture one of those capsules for the patient to inhale. This is what it looks like in its closed position. That picture is in its open position. There's a little indentation here. Supposedly that's a little thumb control, or stick your finger in there, and that opens it up, exposing the mouthpiece and exposing this trigger. You press this trigger, pull this trigger, you'll hear a click. You'll notice the dose counter drop by 1. The powder's been activated. Now it's just simply waiting for the patient to inhale from the mouthpiece. Okay, so open it, pull the trigger, press the trigger, you'll hear a click. The powder's been activated.
It looks like those bubble gums.
Yeah.
Bubble
Yes,
gum.
it is. You know, and everything all wound up in there. All right, that's the Discus. Don't get the Discus and the Dischaler confused. Right? You know what I'm going to do on the test? Both of the Dischaler and Discus is going to be an answer option. Oh, dang it. Right. Flexhaler, Twisthealer, oh yeah, those are going to be the same answer on the same question, same answer option. You know, for these, you know, when you're wondering, okay, how's he going to test us on this? For these, pictures of the devices. Pictures of the devices. I give you this, and of course it'll be in black and white, but it'll be a picture of the device.
Will it show
And
this
it won't,
as well?
yes, and it won't show this. Trust me. I'll turn it around. I'll make sure any identifiable naming on the device is not there. But don't worry about, for example, Adria, that's the drug name. Don't worry about that. We'll talk about that more next semester. All right, that's the Discus. The Handyhaler. Handyhaler, yes, on the test it won't have that written across it. The Handyhaler is the first single unit dose DPI. You would have to load this each and every time you would breathe through this device. So it doesn't contain any dry powder. What comes with the device is a bunch of capsules. I want to call them pills, but they're not really pills. They're capsules. That if you open up if you were to take one of the capsules and open it up, what's inside the capsule? Powder. there's your dry powder. Now, we don't take the capsule apart, we keep it in the capsule. A handy inhaler, when you open the device, so this is just with the top open, here's the mouthpiece. But once you take the capsule, notice how you can still open this further, drop the capsule inside of this chamber. You can close the mouthpiece portion back. When you depress this button inside of here, and you'll see these on, not this Friday, but next Friday, inside of here, there's like what I would describe as nails or tacks, kind of sharp pieces, that when you depress, what do you think they do to that capsule? They puncture a hole in the capsule. Now it's been activated. The patient simply exhales normally, takes in a nice deep breath through the device. What happens when it's all over, once they finish inhaling it, they would have to, I don't think I have a picture, no, I don't have a picture here of that one, but they would open it back up and dump the capsule remnants in the trash and just wait for the next time. Now, problem with this type, and this is true of any one that DPI that you would have to load, is they do come with capsules. Do you think sometimes our elderly patient who also takes a lot of other pills, you know, they have their little weekly pill things that they're supposed to take, that they ask their children or their grandchildren, hey, can you set up my pills for the week? So I remember, and again, grandchild or child of a parent, elderly parent who needs that assistance, you don't know any better, and maybe the patient really doesn't either. You drop one of these capsules and, okay, you take that on Monday and Tuesday and Wednesday and all that's there. And so when the time comes, okay, these are all the pills I got to ingest and take and down with some water today. And then they're wondering, they're walking around, I got this thing. I don't know what to do with it. There's nothing in it. Grandma, you swallowed the capsule that was supposed to go inside of here. Okay, that's happened. And that continues to happen. Good news, bad news? Well, the good news is that them orally ingesting that really causes no harm. Bad news is they've wasted it, they're not inhaling the medication, so they're not getting what they need for their lungs. So good news, bad news. I guess the good part is, okay, no hazards of ingesting it orally, but okay, Grandma, you can't take those pills, we have to have another thing. This is for your inhaler type device, if this is the device their physician wants them to use. But yeah, there has been stories of patients, you know, ingesting these, not realizing, and then they wonder, what's this handy inhaler thing for? There's nothing in it. I've been inhaling from it, but I don't think I'm getting anything. Okay, because there's nothing inside of it. Has to be loaded. We can load it, but of course we can teach our patient to load it, because it's generally not something they're just going to do just during their hospital visit. It's probably something they're going to be on for an extended period of time. All right, handy inhaler. Ellipta. This is another type of dry powder inhaler, and I think of the ones we've discussed so far, probably one of the easiest ones to teach. Okay. Here it's open, but it will look covered when you pull this piece back. Again, that would cover the mouthpiece. How this works is you open the mouthpiece, you will hear a click when that happens. What happened to the powder? It's now activated. It's ready to go. Again, multiple dose DPI. When you open it, you will see the dose counter drop by 1, and the patient can inhale it. When they're finished, close it back up. So there's no trigger, there's no button, there's nothing else they have to do. But this, much like the twist haler, that by simply opening it up activates the device. How many times? Because I know how I would be if I was a new patient and I wasn't familiar with this stuff. I'd take it and I'd open it and close it, open it and close it. When we have our lab, when you ask, John, how come all your ellipses say 0? That's because every student that used it before you went open, close, open, close, open, close, and the dose counter that started at 30. So in a matter of a single lab, we can have dose counters go from whatever they were down to nothing.
It's a shame
So
it doesn't count backwards.
What's that?
That's a shame it doesn't count backwards. You see how many times it's been activated.
Right. Well, trust me, I've broken into these things to see, can I reset it somehow to make it look right for you guys? No. I end up breaking the device, and okay, well, deep fix that one now. But I will reach out with email, I will call, I will reach out to any manufacturer and say, hey, I got a bunch of respiratory students that want to see these things. Anything you can provide me, I would appreciate. That's how I've gotten a lot of the stuff that you will see in the lab. But some things, it's like pulling teeth. You know, okay, we'll send you one. Okay, one's better than nothing. Well, thanks for the one, but can I get a dozen, 20, 30? Enough to give each person their own? You go home that afternoon with all your own DPIs now. But nevertheless, so when you wonder, John, why is most of your DPIs reading 0? It's from all the practice that students before you have had.
Is Trilogy one of these?
It is, and that's a brand name. I'm not talking about drug names, but yes, you will see advertisements for this on TV from time to time. But Ellipta is what I want you to know now. Next semester we'll talk about some of those other, the drug names themselves. All right, the pod haler. Pod haler. Now this is a single unit dose DPI. Comes with a pill or capsule that has to be loaded into the device. So you have to load it into the device. Probably don't have the best pictures here. Oh, I guess this one kind of works. So this is everything completely closed up. You will take this piece off, exposing the pod haler itself. Looks like this. You can kind of see these grooves. You will twist this piece off, exposing the location where you're going to drop the capsule. And then you'll screw this back on. So it'll look like this. This blue button on the back end, you can add, this is the one and only time you can actually point it down to the ground, press that blue button. That activates the powder, punctures the powder. Now the patient, again, can exhale normally, place it in their mouth, and inhale deeply. Okay, the pod haler. Only one type of medication comes in this, like the disc haler, only one type of medication used for very specific situations. Same thing here. This is actually an inhaled antibiotic. Not that I'm testing you on that, but not everybody has an infection that has to take one of these things. But that's what is in this particular device. And we'll talk about this drug that's in this medication soon enough. Okay, but the DPI portion, called the pod haler. Dorza Press Air. Looks simple, and it can be simple if you know what you're looking for. The manufacturer of this device, I think they had good intentions by trying to create a visual feedback to the patient so they can understand that they did it correctly. So here the mouthpiece is covered, protective cap, so this would slide off, exposing the mouthpiece, and this little green button on top, again, how the powder becomes activated, okay, by pressing that green button. But with this, it tries to, like I said, give feedback to the patient. By using this color-controlled window, I think sometimes, and you guys will see it when we do it, understand how a patient can get confused. Okay, so they will press the green button all the way down. That will activate the powder. Again, multiple dose DPI. They will release that green button, so don't keep the green button depressed. They press it one time, release it. The powder's been activated. Now the patient's going to do what? They're going to place the mouthpiece in their mouth, and they're going to inhale deeply and rapidly, right? High inspiratory flow rate. They can look at that window for feedback. Okay, they can look at that window for feedback. Now, when they press the button down, that window should turn green. Green meaning go. Okay, when they press that button, lets us know they've activated the device. If it's not green, it's red, perhaps they didn't press the button down all the way. Okay, so press it again until it shows green. When the patient inhales, again, not keeping the green button depressed, but when the patient inhales, if they inhaled it correctly, that window that was green now turns red. If they inhaled incorrectly, they didn't inhale strong enough, it would still stay green. I think that creates confusion. At one point you want it to look green, and the other point you want it to look red. I think that creates confusion. Okay? But initially it should be green. If they inhaled adequately, it will then turn red. I guess indicating, okay, you got it, stop. That's it for your inhalation of this device. I do like that it gives feedback to let the patient know they inhaled deeply or fast enough. The other ones, they can inhale super slow, they wouldn't know. Unless it was me kind of coaching them going, no, you need to breathe that in pretty rapidly, a little faster than what you're doing. But this one at least gives some sort of feedback to the patient that their inspiratory flow effort was adequate. Yes. Right. If they did not inhale correctly, if they didn't inhale strongly enough, fast enough, it would still stay green. Yes, yes. Yeah, inhale faster. Inhale faster. You know, for us in the lab, you guys can see this. The problem is, I wouldn't say any of my inhalers are clean. So by no means are we, you or I, going to breathe through these things. So we will never see this portion. Because again, I'm not breathing through it. We can press it all day long. That's fine. That's not going to hurt anything. But I'm not going to inhale through it to see the color change the way it's supposed to. So you walk into the lab right now, you may see everything looks green. Okay, great. It's waiting for us to inhale. And obviously, you heard me say it. Our inhalers are not clean. Do not place them in your mouth.
And this would be a multi-dose?
Multiple dose DPI. Yes, multiple dose DPI. You're not having to load it, anything like that.
The patient inhale, but not everything. Like with other devices too. Over time, it became like clog or something, accumulate the powder or something.
If they've inhaled it correctly, it should not accumulate powder.
If they're not like.
Oh, over time,
Yeah.
yes, it gets stuck, kind of in the device or apparatus. Questions?
I guess I'm wondering if there would be a time you wouldn't use an inhaler if there's a pillar liquid that is as effective, or you always wouldn't try to use an inhaler to get the effect?
Well, it depends. Sure, but the ideal thing about inhaling medications to the lung, if we're trying to correct a lung issue, is that's the target. If you give me a pill, it's going to have to go, I'm going to have to ingest it, some of it's going to end up going to my stomach, some of it's going to be disintegrated, it's going to go through my liver, it's going to have to be processed through my liver before it ever reaches my bloodstream. From my bloodstream, then it's going to have to reach the lung. So the more places it goes and goes through, that dose of medication gets dramatically reduced. Meanwhile, exposing me to all the potential side effects that having a dose this high initially started. So if I can give a dose here and it's directed exactly to the lung, again, I can give a much lower dose of that actual medication, again, not exposing the patient to any of the potential side effects.
You also want fast acting too, correct?
Yeah, if it's going directly to the site of action, sure. It's going to start working quicker. God bless you. So how do you know when a dry powder inhaler is empty? The counter, the dose counter number, it will always decrease, letting you know how many doses are left. That's if it's a multiple dose DPI, but what if it's a unit dose? When you run out of the capsules or I always want to call them pills, but they're capsules because the powder's inside of them. You know how many those are left. If this is something the patient's supposed to take every day and they're down to 2, they should have called days ago when they were down to maybe a week's worth of doses just to make sure they get it refilled or a new prescription if they had to get that from their physician. All right. Questions on the different inhalers?
Are you going to be just testing us on, you said you're just going to do pictures, but are you going to be asking like, is this a single dose or not?
I could.
Is it-
Yes. Yes. Yes.
So if it's a packet, it's a single dose. If it's like contained.
If everything is already, if the powder is already inside, multi-dose DPI.
Okay.
If it's something you have to load,
Single dose.
single unit dose
Okay.
DPI. If it's the disc haler is the only multiple unit dose example, right? Because inside of that blister pack, there's 4, there could be even some that have 8, but generally 4 doses. So it's still a unit dose, but it has 4 doses in there. But they don't necessarily have to take all in the same sitting or same time. As opposed to these, which most of them you can tell are already loaded with the dry powder.
So that's multi-dose.
Multiple dose, multi-dose DPI.
And then the one with the, like the four,
The discaler.
Multi-unit dose.
Multiple unit dose, just to create confusion. Right. And then as far as, questions asking about the individual device, that would be, you would see on the test pictures of the device, and yes, I'm not gonna have the word discus anywhere on there, or flexhaler, or antihaler, anywhere in the picture. Yes?
What's the difference between discaler and discus?
Let me bounce back real quick. Alright, so discaler, again, the dry powder's in a foil pack. Notice how these 4 gets placed in here. Okay, so each one of these is a separate dose, so 4 doses. The discaler, kind of more, lack of a better word, hockey puck shaped device. All the doses are already loaded inside, all wound up inside this foil, or inside this cap, with each one of those little kind of triangles representing a single dose of the dry powder.
Makes me think of like cap guns.
That's what I always think of too, but I feel like I'm aging myself and people have no clue what a cap gun is, right? Sorry, thanks for helping me feel young again.
So the other one though is a single multi, is what you said?
Yes,
Okay.
yes. And just make sure you remember, the order of these things is not necessarily unit dose, multi-unit dose, or unit dose. It's kind of bouncing all over. But most of them are multiple dose DPIs.
So for the discaler, when the 4 or 8 dose are finished, you replace this.
Correct. You're finished with that one, and yes, if you need another one for another day, that would be another foil pack that gets placed inside there. All right, let me get that one. Was that my last slide?
Yeah.
Wasn't my last slide. Okay. Any other questions? I'll give you my questions. You can see on some of my questions today, the questions that I could potentially ask come test time. Okay? So, first question. Of the key mechanisms of aerosol deposition, which one causes the particles to settle out of suspension and deposit due to gravity? This can also be increased by breath holding. Was that inertial impaction, Brownian diffusion, sedimentation, or emitted dose? Sedimentation. That's why we encourage breath holding when the patient takes their inhaled medication. So this one was C, sedimentation. Everybody snap a picture of that if you wanted it. Okay. Got it? Yeah. Which of the following describes the best way to use a metered dose inhaler without using a spacer or holding chamber? So let me be clear. We're not using a spacer or holding chamber. We're just using the MDI. Do I A, activate or press the inhaler just before you begin to take in a breath? Do you activate or press the inhaler just after you begin to take in a breath? Do you activate, press the inhaler just after you begin exhaling, or activate, press the inhaler during exhalation? Well, let's eliminate the exhalation ones, right? Because I'm not going to do these during when the patient's exhaling, right? So I'm going to do these during inhalation. So just do I, and this is why I hate the analogy that MDIs are press and breathe devices. Right. Press and breathe, because
Breathe and press.
you got to breathe, press, and keep breathing, you know. So start the breath, press the inhaler, continue breathing in, do the breath hold, now you're done. So that B is the correct answer. And that's again without using a spacer or holding chamber. What if I am using a spacer or holding chamber?
You could do it with either.
Well, then I could depress it inside the spacer or holding chambers of medication. Then I can, as long as I'm not waiting 20 minutes, you know, I press it and okay, now I can inhale the medication from the spacer or holding chamber. Now, I forgot to say this with the spacer or holding chamber. Obviously, using a spacer or holding chamber is going to be more effective, right? Especially eliminates the coordination issues that our patients have. But what's the drawback? These things, these MDIs are supposed to be small, convenient, portable, fit in my pocket. If you say, okay, well, here's your inhaler, and oh, and by the way, here's your spacer. So much for portability anymore. So that's why you're going to find a lot of folks don't use a spacer holding chamber, because it eliminates the portability of the device. And outside of the hospital setting, I'm cool with that as long as their technique is correct. But many times people do this one when they're not using a spacer holding chamber. And all I do is I picture that one slide with the purple aerosol all loaded up in the back of the oropharynx. There's very little of it reaching the lung when they do it this way. All right? So just make sure we're having them start the breath in, press the inhaler, continue breathing in the maximum with the breath hold. All right, next question. Of the following dry powder inhalers, which one requires the patient or respiratory therapist to load a capsule to the device? Was that the discus, the handy-haler, twist-haler, flex-haler, or ellipta? This one's the handy-haler. Very good. I know it's the first time we've talked about this stuff, so it might not be totally up there yet. But yes, of these 5, the handy-haler is the only one we would actually have to physically load. The others are the multiple dose DPI. Sorry. All right, so here's another DPI question I didn't need to give you a picture with. All right, here's a picture. Is this the twist-haler, flex-haler, to doors of press air, discus, or handy-haler? This one's the flex-haler. Very good. This one's the flex-haler. How do you activate this one? By rotating the bottom. You'll rotate it until you can't, rotate it back, and you'll hear a click. Now let me say, not this Friday, but next Friday when we have a lab, my flex-halers, no telling how many times they've been rotated. I was messing with some last Friday when my group left. I went to make sure we still had everything out. I grabbed one. I'm like, this one can just do a whole 360. It's been turned and rotated so many times. So if that's the case, let me know, and we can get you one that actually does function the way it's supposed to. But yeah, I'm like, I'm waiting for the click, and it's still turning the bottom. I think it's been turned way too many times. All right, so this one's the flex-haler. What is this one? This is the 2 doors of press air. You press the green button. Again, the little window changes color so you can see that you properly activated. It will turn green. Patient would inhale. As long as they inhaled at the right speed, the window then turns red. Again, with breath holding, yes or no? Ideally, everything we've talked about today, ideally with a breath hold. All right, next one. What is wrong with this picture? This, as you guys are looking at this picture, and I'm not going to throw anybody's organization under the bus, this picture was on one of our local hospitals' flyer for their asthma clinic. And I looked at the flyer and I said, wait a minute, and I'm sure this was just some sort of, not necessarily a picture they took, it was something that was probably the marketing company they used for their flyer. Anybody see what's wrong with the picture? The cap is still on. The cap is still on. And her teeth are in the way, but the cap is still on. That's beside the point. But what a great picture to put for your asthma clinic flyer and all the services you can do when the picture's not even right. Now, we're the only dorks that I see that, right? Somebody probably wouldn't notice it or recognize it, but anybody who probably takes an inhaler or one of us would probably say, wait a minute, that doesn't look right. Yeah, the cap was still on their MDI. All right. It is now 11:30, and I am done with part 1. Okay, let's take a break. I hate to say, okay, no questions, but let's go ahead and take a break just because of the time. We'll start back at 12. And do the last little bit of chapter 8. And then I'll answer any questions you guys have for Monday's test. Okay? So take a breather.
So if you put a question saying what does DPI stand for,
would I do that?
right? What can you please put one of the answers?
take tax spots, right?
Yeah, I think I waited an hour right now.
Yeah, right.
But those are
You'll never get that one wrong.
I guess they're all
This is a single, just because you have to put
Yeah.
the capsule in every initial.
So those are not,
That's
those are multiple, yeah.
Sorry again for the delay.
What is this snappy today?
I have meetings this afternoon.
Oh, nice.
Thank you, I appreciate that.